thank you for coming today for skin changes, dermatology. So I'll let Dr. Moore introduce herself and continue our presentation. So we've got Dr. Helen Moore, consultant dermatologist, with us today. Thank you.
Thank you. I'm not actually a consultant dermatologist. I was a GP at Ferry Hill practice for 23 years, and I'm a GP with a special interest in dermatology. So I do work in the hospital alongside the consultants up until the end of next month, when I retire completely. But I can't claim to be a consultant. But hopefully I can give you some tips that will be helpful through the slides. So I was trying to think of a sort of name that incorporated menopause and skin, so changing skins, I called it. And the outline of the talk is that we're going to look at changes that occur in the skin with age, that we're breaking those into physiological changes, so those are the changes that occur normally in people, and there are intrinsic and then extrinsic factors that affect that, so that's grouped into intrinsic and extrinsic aging changes. And we'll look at some site-specific changes, particularly the face, the genitalia, and then other areas of the body. And then there are pathological changes, so they're changes that more involve a sort of disease process rather than just normal changes that you get with aging. And then we'll look also at how we can maybe reduce or affect those changes that occur over time, and particularly with the menopause. So the skin is the largest organ of the body. It is mainly made up of collagen, which is a protein that maintains the skin elasticity and resilience, and is also found in nails, hair, muscle, bones, and the blood. And collagen deficiency in women correlates with estrogen deficiency more than it does with chronological age. So as soon as your estrogen levels start to drop, that's what has the effect on your collagen levels. So the physiological changes, if you can get your tongue around that, starting physiological changes that are associated with the menopause. So the hormone changes that occur at the menopause are the trigger for the age-related skin changes. So female hormones do exert a protective effect on the skin and delay or slow any aging changes that can occur. And as the skin ages, it is associated with increased dryness of the skin. So that's the main thing that occurs. So with age and the menopause, you get a drop in your estrogen, you get less collagen produced, and that is 30% in the first 5 years after the menopause, and then 2% in each successive year after that. So estrogen helps the natural hydrating mechanisms of the skin. So as the estrogen levels fall, you produce less sebum, you produce less hyaluronic acid and ceramides, all which help the barrier function of the skin. And so as they reduce, you get more evaporation of fluids from the skin becomes more dry, and dry skin tends to be itchy skin, so you feel much more itchy generally. So we're looking at the intrinsic and extrinsic effects of aging. So intrinsic is much more just chronological. It affects the whole body, not just sun-exposed sites. And it affects everybody from the age of sort of 50, 60 onwards. But women will see those changes earlier than men due to the lack of the protective effects of the estrogen. Extrinsic aging is factors that are then superimposed on those. So particularly how much sun exposure you've had, whether or not you've been a smoker. So that affects much more the sun-exposed sites, particularly your face, your neck, and your arms. So with intrinsic aging, the main things that you see is the skin becomes dry. It's often quite pale, smooth, thin, rather transparent looking, unblemished, with fine wrinkles and a bit of skin sagging or laxity due to the decreased elasticity. So here you can see how you get this very fine wrinkled skin, and you can see the vessels through it very easily because there's less fat underlying the skin, and you get these sort of some brown marks on the face, and it's quite smooth, unwrinkled, very fine wrinkles rather than the thicker wrinkles. With extrinsic aging, this is much more due to the effects of the sun on the skin. So sun damage and photoaging, they'll be more apparent in people who have a very fair complexion with blue eyes. People who've spent a lot of time in the tropics or subtropics, or who've lived at high altitude, spend a lot of their working life outdoors, or have been frequent sunbed users. And the effects of the sun on the skin partly depends on your genetic skin type. So the UV light every day causes thousands of little damages to the DNA, and this then causes the elastin that's deposited in the skin to be a sort of disorganized elastic fiber-rich matrix, which is what you see as solar elastosis, it's known in medical terms. And you have a much thickened appearance of the skin with bumps and wrinkles and furrows and a sort of yellowish complexion. Whereas people with a fairer skin type, they get more freckling and a rather atrophic photoaging, so the skin is much smoother with some dilated blood vessels visible. And the darker your skin type, it tends to be a more thicker skin with rough and deeper wrinkles. So here we can see some of the thickening. Here you see the bumps that you get with solar elastosis and that slightly yellowish look and quite deep, thick wrinkles. So the more sun damage you've had over a lifetime, then the more that can affect the changes in the skin. And the way obviously of preventing those effects is by using effective sun protection, using high factor sun creams and protective clothing. Once you have those changes, any treatments really involve sort of cosmetic therapies like laser, dermal fillers, and I think you've got a talk coming up in the not too distant future that probably goes into that a lot more. Effects of smoking, they also affect the quality of the skin. So the nicotine narrows the blood vessels and reduces blood flow, and oxygen and nutrients to the cells are reduced. So again, that affects the collagen and the elastin in the skin. There's also just the heat from the burning cigarette can damage the skin, and the muscle, the facial expressions you pull when you're smoking increases, and sort of the wrinkles increases that you get around the lips. So this is a lot of the changes that you can get specifically just from being a chronic smoker. Effects of nutrition on skin aging. So we do know that a healthy diet, so fruit, vegetables, legumes, herbs and teas, can all help reduce wrinkling, dryness and atrophy because they contain antioxidants, vitamin C and linoleic acid, which is present in vegetable oils, seeds, meats and eggs. So they did do a study in Greece and involving people who lived in Greece, Australia and Sweden, which showed that if they had a higher intake of vegetables, olive oil, fish, legumes, which are chickpeas, beans and peas, that gave them resilience to photoaging. And that was also if they had lower intake of margarine, sugar and dairy products. So there's no doubt that a healthy diet does have an impact on your skin. And we know that a higher fat and carbohydrate intake also can cause increased thinning of your skin and increased wrinkles. So on the face, the local effects that you see on the face, so you have less collagen, the skin is less elastic, you get reduced fat in the upper part of the face and then sometimes increased fat in the lower part of the face, so you get this jowl effect where it's rather heavier in the lower part of the face, particularly around the jaw and chin bones. And there is a study that suggests that if you look at the placement of people's wrinkles on their face, you can tell whether or not they've got osteoporosis or thinning of their bones elsewhere. Dryness of the skin is also associated with increased wrinkles, and people get these brown spots, which are known as age spots or wisdom spots, or whoever you happen to be talking to. You can also get increased unwanted hair growth on the face and thinning of the hair on your scalp and other body areas. So here we can see some of this. So this is a bit of the sort of the heavy jowl effect and the thinning up at the top. We've got some solar elastosis in there with the slightly yellow and thickened skin. And then we can see these brown spots, these age spots that come. And so they are dependent partly on your genetic skin type, and but also the more sun exposure you've had, the more of those you will tend to get. Local effects in the genital area, again due to the reduced levels of estrogen you're getting at the menopause. So you get some vaginal atrophy, which means the skin gets dry and thinned. It's change in the skin pH, which means you would increase risk of getting recurrent thrush or bacterial vaginosis, which is another bacterial sort of low-grade infection you can get in that area, and also water infections, and increased risk of water infections. You can find that you've got discomfort during intercourse. There's less fat deposited in the labia, and the skin in that area feels loose and less elastic. And then there are specific pathological conditions, so skin diseases that can be worsened at the time of menopause. It may be pre-existing or can tend to occur at that time, which are not sort of normal aging changes, but one needs to be aware of and not attribute everything just to being due to the menopause. Other body areas affected, so these physiological changes due to the menopause, dryness, irritation and itching can occur in other areas of the body. You find that wound healing takes longer after injury or surgery. Photoaging is particularly evident on the hands and the lower legs. You have this reduced fat layer, so your blood vessels become more visible. And there are various skin lesions, skin changes that occur that we'll be looking at a little bit later, some slides. So the things called seborrheic keratoses, which are these warty growths that can come. There are cherry angioma, telangiectasia and viral warts. So we'll look at all of those a little bit later on. And then there's something called female pattern alopecia, where people find that they get thinning hair on the head. So pathological changes, so these are more related to underlying skin conditions, can be again worsened at the time of the menopause due to changes in the skin pH and the hormone fluctuations. So if you already suffer with rosacea, eczema or psoriasis, this can be worsened at the time of menopause, and also it can trigger an acne that you thought you left behind many years before. So seborrheic keratoses, also known as seborrheic warts, people worry about these because people think maybe they are melanoma or they're moles that are causing concern, but they never turn into anything nasty. They are benign skin lesions that come from the top layers of the skin. You get more of them with age. They can be all colours from light tan through to black, or they can also be pink. They're round or oval, flat or slightly raised. They can be tiny or they can be quite large. And they just involve the top layers of the skin, so they often feel like you could just scratch them off. They're like stuck-on lesions rather than being within the skin itself. So here are examples. I'm sure most of us will have at least one of these somewhere. And some people get a profusion of them, so some elderly people you'll find that they're really covered in them. But these people often come to their doctor very worried about these, particularly because they do change with time as well. But we quickly can look at them with a dermatoscope or look at them with a naked eye and say they're nothing to worry about. They're a nuisance rather than anything else. So the other changes, so you can get cherry angioma. These are little red dots that appear with age on the skin. They can occur on most parts of the body, and they can bleed if they get scratched or rubbed. They're also known as senile. A lot of these things get senile. It just means getting old, but yes, it doesn't sound very flattering. So senile angiomas or Campbell de Morgan spots, which sounds a lot more exotic. And they can occur from 30 onwards. So some people get lots of them, some people don't get any, but they are one of these things that people accumulate with age. Telangiectasia, so these are little spider veins, small dilated blood vessels that occur near the surface of the skin. Again, they can occur anywhere on the body, but you often find them around the nose and cheek area. When we were talking before about sort of fair people have more of a thinning, atrophic skin changes, you often see these blood vessels appear there. And also around the lower legs and ankles associated with varicose veins, people often get these dilated blood vessels. And then there are all sorts of other warty lesions that can appear. Sort of heaped up areas of keratin, a lot of them there can be viral warts, so there is the human papillomavirus that causes little warty things. Often you don't know whether they're warty or seborrheic unless you remove them and send them off, but they tend not to be anything to worry about. So here, you can see these little red dots. Here you've got some dilated veins, and there's a nice warty lesion. So, female pattern alopecia. This is something, again, that's thought to be constitutional or physiological. Often you can find that you've inherited it. Maybe one of your other female members of the family generations before tended to have their hair thinning. And it can occur perimenopause or even earlier, but will often increase around the time of the menopause, and you get this diffuse thinning of the hair and widening of the midline hair parting, and then you also start to get a bit of recession from the front. It's important to check the thyroid and iron levels, because those are things that can be improved if they're abnormal, and that can add an additional level of diffuse hair loss, but it's not the cause of female pattern alopecia. It is difficult to treat anything to do with the hair, but minoxidil, which we can't prescribe but can be bought over the counter, can help. It actually helps thicken the hair so that it gives the hair feels less thin, and over a period of 12 months you'd expect a 50% improvement. Sometimes it dips before it starts to improve as the thin hair gets pushed out and the thicker hair comes through behind it. You want to ask for the 5%. It was always 5% was for the men and 2% for the women. And if you wanted 5%, you had to get a private prescription or lie and say it's for somebody else. There are some now that seem to promote minoxidil extra strength for women, which is the 5%. If you buy it online, it's cheaper and you don't have to worry about saying who you're buying it for. But if you go somewhere and they're sort of head, you just say you're buying it for your partner or somebody else. There is a tablet called spironolactone that, particularly in quite young women who are suffering with this, they sometimes consider starting them on it. It can be prescribed in general practice, but I think maybe GPs are not always that familiar with it or that happy to do that. And the trouble is, once you're on it, you really need to stay on it, because as soon as you stop taking it, it will go. Same with the minoxidil. If you stop those treatments, it will return to where it was before. So it is a sort of long-term strategy. So here you can see the sort of changes that happen. So basically that hair parting just starts to look wider. Hopefully, not everybody goes all the way through those stages. And then you start to get the widow's peak, the recession in the front there. So looking at what we can do to try and reduce or slow down some of these changes, I mean, it is looking at general skin care, and because the effects of the reduced estrogen and the aging on the skin is having a similar effect to those people who suffer with eczema, you've basically got a reduced barrier function. Anybody who may have had eczema in the past will know very well what is required. Your skin is losing moisture more easily. The increased dryness is resulting in itching, and any irritants, so any perfumes and preservatives and things, can penetrate more easily and maybe set off an irritant or even an allergic reaction. So your skin is much more sensitive to different products. So the things you have to do is avoid anything that contains fragrances and preservatives. Avoid soaps, bubble baths and shower gels, anything that creates a lather, because that removes the natural greases from the skin. The skin is already producing less sebum and other greases than it was before. The chemical that creates the bubbles strips those greases off the skin and makes the skin even drier and more inflamed and more irritable. So you need to avoid all those soaps and use a washing cream instead. And any cleansing wipes products, because they contain some bit of alcohol and all sorts of preservatives and things. So you really should avoid any of those, so that they can act as an irritant to the skin. So instead you need to use a washing cream. So instead of soaps, you need to be washing with a washing cream. You should have shorter, cooler showers and baths. Frequent applications of moisturiser, particularly when the skin is still damp. So you have your shower, you use your washing cream to wash with, you dry yourself off gently, dabbing your skin dry, and then you reapply possibly that same cream as a moisturiser after your shower, while the skin is still a little bit damp. And this all helps boost hydration. Avoid aqueous cream. It's cheap as chips, but it's very variable between different manufacturers. It contains all sorts of additional ingredients like sodium lauryl sulfate that can trigger quite bad allergic reactions in some people. It also often contains variable amounts of perfumes and preservatives. So in dermatology, we say bury any aqueous cream at the bottom of the garden. We don't like it. Use rubber gloves when you're washing up or using any sorts of detergents or cleaning products, because they'll just strip all the greases off your skin. Use a good sunscreen, even in the UK, when you're out and about between April to October, when you're out and about, gardening, walking, playing golf, whatever you like to do, make sure you put your sun cream on. And that will help reduce those age spots, those brown spots that people get on the skin, help reduce the risk of cancer, although a lot of that damage has been done in your 20s to 40s. You want to reduce any further risks. And there are creams that certainly claim to help improve the quality of the skin, and the products to be looking out for things that contain retinoids and retinols, antioxidants and peptides. So I just took a screenshot of a few different products that are available, but if you Google retinols, and there's a whole plethora of things out there that people might find helpful. I don't have data on how effective they are. I mean, I think the thing is, always never to expect too much, and just those general measures of hydration and healthy diet are probably the best things to be doing. As far as vulval irritation, so that's a very common problem around the time of the menopause, and again it's similar. Don't use soaps, cleaning wipes, avoid nail varnishes and acrylates because they can sometimes cause a bit of an allergic reaction. Don't overwash in that area. People find that they're washing 3 or 4 times a day, and that can actually cause irritation of itself. Don't wear synthetic underwear because that can aggravate the problem. So you want to wash with a bland emollient. Use a pH balanced vaginal lubricant if you're needing one, which is free from silicone, perfumes or glycerin. So these are some of the manufacturing names that they come under, the product names. There's Silk, Yes, and Liquid Silk. They're all used by in the dermatology department. Keep your nails short so you're not in the middle of the night when you're half asleep giving yourself a lot of trauma down in that area. And obviously if you're not already on a systemic HRT, then you can consider topical estrogens. In fact, I was just in chemist today and I noticed, I took a photograph of it, there's something called Gina, which is an over-the-counter topical estrogen that you don't need a prescription or anything for, so that's a new one to me, but presumably it's a lower dose.
No, it's just the same as Vagifem and Vagirux.
So that can definitely be helpful, and it just helps reduce the quality of the tissues in that area and helps reduce a lot of those symptoms. So the lifestyle changes are all the ones that you would know already. Stop smoking, have a balanced diet, exercise, avoid using the soaps, use lots of emollients, use good sun protection. This isn't specific to the genitalia now, this is just your barrier clothing, and consider topical HRT for the genital area if you're not already on HRT for other reasons. So looking a bit more at sort of pathological changes that can occur during menopause. So you can, as I said, you can get an exacerbation of pre-existing skin conditions. So eczema, psoriasis can become worse, rosacea can worsen, and you can get some acne. There's also something called intertrigo, where you can get a rash affecting the skin folds of the groins, under the breasts, and in the apron area. And that's often associated with a candidal infection, a bit of thrush in that area. So that may need medical management with an antifungal steroid combination. Keeping your weight down helps reduce some of those just because there's less sort of contact. Keep the area well moisturised and avoid using talcum powder. There was probably think the generation before us were very keen on putting talcum powder on everything, and that just dries the skin. It can act like sandpaper, make a lot of these things worse. And if it keeps coming back, you need to check that there's not a reservoir of infection somewhere else. So for example, toenails, check that there's no fungal infection between your toes or your toenails. You're drying your feet and then you dry other areas and you sort of spread it. So that needs to be checked and treated if it is there. So some nice pictures of intertrigo. Sorry, if you ask a dermatologist, you'll get gory pictures. So venous stasis, varicose eczema, that's also a big problem that can cause a lot of morbidity, a lot of really affect people's lives. And this is basically an eczema affecting the lower leg, which can then lead to the development of leg ulcers. These do increase in risk with age, and they do appear more in women than in men. It's partly due to the valves in the legs not working properly, and this causing damage to the overlying skin. So you have increased pressure in the veins, which pushes some blood and blood products into the surrounding skin, although we don't completely understand why it works, and then that causes some breakdown of the skin and inflammation. So you have increased risk of developing this if you're overweight, if you're not very mobile, if you've got leg swelling maybe due to some heart failure, if you've got varicose veins, or if you have in the past had either a clot in your legs or some infection in the tissue, some cellulitis of the tissues there. And what you can see, depending on the severity, is you can have just very mild changes in the skin colouring and dryness to a very inflamed eczema with red spots, scaling, weeping and crusting. And it's often mistaken for infection, but it's often more just an inflammation. It can be very itchy or painful. You can get swelling associated with it. Sometimes some white patches of thin, scarred skin, which is known as atrophy blanche. Sounds like a nice pudding. Skin can be thickened and woody in texture, which is lipodermatosclerosis, another tongue twister, and it can trigger secondary eczema to occur elsewhere. So here's some of the changes you see. So I don't know if you can see here, but there are white patches there, which is your atrophy blanche. This is, if you felt this, would feel really quite hard and woody. And a lot of those colour changes are relatively permanent. So you can make the redness settle down, often with topical steroids, but there will still be permanent discoloration where something called hemosiderin, which comes from hemoglobin, has actually been deposited in the tissues and gives that sort of browny appearance. So to treat varicose eczema, and the reason for treating it is partly to reduce your risk of getting an ulcer, which can then take a long time to heal, and reduce the risk of cellulitis. Again, lots of moisturiser, that it makes the skin in that area more supple and less at risk of breaking down. When you do sit down on an evening, put your legs up, and that helps improve the blood flow to so everybody put your legs up. Helps improve the blood flow. So they should be hip level at least, and if possible a bit higher. Keep active as much as possible and avoid standing for long periods. So if you do have to stand, just sort of go up and down on your heels, just so you squeeze those muscles and pump the blood back up. So it's standing for long periods, sitting with your legs down, going to sleep in the chair. All of these things can increase your risk of getting this varicose eczema later. Elevate the foot of the bed so you're actually sleeping with your legs above your heart level. And this is easier said than done, but avoid knocking or trauma to the legs on supermarket trolleys or cupboards, because once they are injured, they take a long time to heal. Sometimes compression socks can be prescribed, but you should have something called a Doppler test done before that, just to make sure the arteries are fine, particularly if you suffer with diabetes or any arterial problems, because you don't want to compress those arteries and not allow the blood to get to the feet. It's the veins you want to be compressing, and if the artery is a bit compromised, then you shouldn't have compression. If the skin is very itchy and inflamed, then you should see a GP or a nurse practitioner. You might need a bit of topical steroid on there. Again, check your toenails for any possible fungal infection, because that can make the eczema worse, and that should be treated. And a few people would actually benefit from varicose vein surgery, but they would be assessed by a tissue viability nurse and the vascular surgeons to see if that would help prevent or reduce leg ulceration. So here you can see you can get ulcers start very small, and then they can quite quickly extend and become very problematic. We've all had your dinner. So to prevent this happening, the main thing is to keep physically active, keep your weight down, put your legs up when you're sitting down, use lots of moisturiser. I mean, moisturiser is basically the theme of the day. That will solve all your problems. And if you don't need compression socks as such, just some of those tights and socks that you can buy at Boots or M&S or somewhere that have a little bit of compression and can help. So solar keratoses. So these are bits of sun-damaged skin occurring in those sun-exposed sites, your forearms, backs of hands, face, ears, lower legs and lips. They are triggered by sunlight, which probably happened 20, 30 years previously, and you get patches of rough, scaly, dry skin with a bit of warty scale on a red background. They can be quite itchy or sore. The risk is that they can develop to a skin cancer. So this isn't just your sort of photo-aging, this is actually a pre-malignant condition. This is where you're getting patches of sun damage that can be treated, and if not treated, so a third would stay the same, a third can get better, a third could progress over a long period of time to form a skin cancer. And if you suddenly got a raised lump or ulcer which develop rapidly, then that could be a local skin cancer, and that should be checked by your GP. If you're on any form of immunosuppression, that increases your risk of developing skin cancers, so you should be even more vigilant to checking your skin. So these areas of keratosis, you can see there's a sort of red background. This would be a grade 1, so just when you feel it, it's quite sharp scale. So often you can feel them better than see them. If you close your eyes, you can feel this sort of very sharp scale. It's often on the backs of hands. This is more grade 2 and grade 3 patches of solar keratosis. And at this level, it can be treated quite easily and prevent you having that risk of developing some skin cancer. Also, people who have a lot of solar keratoses are more likely, if you get a new lump, that is more likely to be a skin cancer than in somebody who doesn't have any evidence of solar keratosis. And this is where it actually progresses more to what's called a squamous cell skin cancer. So there are 3 main types of skin cancer. There's the melanoma, which is the most dangerous. Squamous cell still requires a very urgent referral to hospital, but is a lot less dangerous. And then there's something called a basal cell, which is very slow growing, not life limiting, but needs to be probably cut out because it will just continue to grow and cause problems. So again, the way of avoiding this is to protect the skin from too much sunlight, so avoid lying out in the sun abroad between 11 and 3, wear your protective clothing, wear your sun creams. The best age to be protected is in your child and teenage years, because a lot of this sort of occurs several years after you've had the sun damage. Avoid sun lamps and sun beds, and be skin aware, so check your skin regularly for new warty lesions or keratotic lesions, and also changes in pigmented lesions. You'll notice the intended error there. You shouldn't necessarily be on vitamin D from April to October, but from October to April. So over the winter months, none of us are getting enough vitamin D, really. So pigmented lesions, you can get new brown warty lesions, which are probably the seborrheic keratoses that we looked at earlier, and they appear increasingly from 40 years onwards. You can also get new moles, which are pigmented nevi, and they're much rarer to occur after your late 40s, early 50s. So if one does occur, it's much more likely to be something to be concerned about. So a new or changing mole needs to be checked to exclude a melanoma. In fact, moles that you've had most of your life can gradually disappear as you get older. 70% of melanoma appear where there was never a mole there before. So people take a lot of intention and sort of put plasters over moles when they're in the sun, but in fact it's the whole of your skin, not just those individual moles you need to protect. And most melanoma appear de novo, so where there was never a mole before. 30% will appear in a pre-existing mole. And there's something called the ABCDE rule. So if you're looking at a mole, if it's very asymmetrical, if it looks like a country, it's got a very sort of irregular border, then that would alert you to make you concerned. If the border in some areas is not clearly defined but appears to sort of fade out or blur out, if there's more than 1 or 2 colours in there and they're not evenly distributed, if it's bigger than 6 millimetres, and if it's evolving, so if it's changing, growing, any of those features should send you off to the doctor. Most come saying this mole is itchy, but it's probably not the mole that's itchy, it's just the skin in that area that's itchy. And itching is a very non-specific, it doesn't really excite us very much, where any of those changes should cause us to pay attention. And of course anything that bleeds spontaneously. So here you can see those different changes. So you've got this asymmetry, it's not a nice round or oval lesion, it's really all over the place. It's got this irregular border that maybe fades out in certain areas. There are different colours within it. If it's bigger than 6 millimetres and if it's changing, then that would obviously cause you concern. So back to the genitalia. So pruritus means itching. So pruritus vulva is probably a step on from vulval irritation. This is when it's really affecting your life significantly. Severe itching causing active distress, often worse at night time. It can occur at any age, but tends to be worse around the peri or premenopause time due to that drop in estrogen causing increased skin thinning and dryness. And again, as we've said before, it's made worse by soaps, perfumes, certain creams, sweating excessively in that area. Condoms can sometimes aggravate it, and wet wipes. So management, use a bland, unscented moisturiser, use it liberally and often, and possibly keep it in the fridge, and then it has a cooling effect as well when you put it on. Avoid soaps, shampoo, bubble bath. Wash gently with a washing cream, try not to use a flannel or a sponge. Avoid any perfume, sanitary products, panty liners, antiseptics, special vaginal washes, any of that sort of marketed stuff. Avoid washing only with water, that can dry the skin as well. So use your washing cream, and a shower is better than a bath. Don't put your underwear on until the vulva is fully dry. You can dry it gently with a soft towel or even a cool hairdryer. I don't know if anyone does that. Use an unperfumed vaginal moisturiser or lubricant. Avoid deodorants, avoid shaving if you can, avoid dyed toilet paper, condoms lubricated with spermicide, and avoid getting into that scratch itch cycle, because the more you scratch, you release histamine in that area, that makes it more itchy, and you just end up on the ceiling. So, and the more scratching, it thickens the skin in that area as well. You get what we call lichenification. You might even want to put on cotton gloves at night time. That would help avoid you doing something in your sleep, and avoid nail varnish, because again that can trigger a bit of an irritant reaction. Wear loose clothing, 100% cotton underwear, change it daily. Avoid tight-fitting cycle shorts, leggings, tights, tight trousers, and wear skirts, dresses, stockings, or no underwear at all. Get away with it. And if you're not already on systemic HRT, or even if you are, then you might want to consider some local estrogen to that area. Antihistamines can sometimes help reduce the itch. If it's very severe, you might need some topical steroids from your GP or nurse practitioner. Sometimes people are just recurrently fobbed off as having thrush. They may well have thrush because you are at increased risk of having thrush, but if you keep getting it, you really need to have a swab to say whether there is thrush there or not, and if it is, then treat it effectively. And there are other skin conditions that can occur in that area that can either appear or get worse around the time of the menopause. So somebody at some point, if it's becoming very problematic, needs to have a look to make sure that you haven't got something called lichen sclerosis, lichen planus, or an eczema or a psoriasis of that area. So, you know, not everything is due solely to the menopause. There can be other processes going on there as well. So of that list, I'm just going to look a little bit at lichen sclerosis, because that is something that people need to be aware of, and it should be treated if it exists. So it is a local skin condition, can occur at any age, but it often is worse at the time of the menopause. Often first appears in middle-aged women. I'm not sure I've worked out when middle age occurs. It's obviously something I'm still aiming towards. It itches worse at night time. You do get very specific skin changes. You get white areas. It often can extend to around the anal canal and natal cleft. You get fissuring and some erosions, and it's very itchy and uncomfortable. And if untreated, you can get architectural changes. So in fact, the size of the vaginal opening can get smaller. You can get hooding over the clitoris. So it can be quite, obviously that has a big impact on people, and it can be quite deforming. So, and that can make sexual intercourse become difficult and painful. You are at increased risk of thrush and other infections, and it can be mistaken just for being recurrent thrush or menopause-related symptoms. So somebody does need to have a look, either yourself with a mirror or getting a doctor to have a look to say, okay, I think this is what's going on. And it's one of those things that can often progress gradually over many years. So the treatment for it is quite strong: topical steroids, regular emollients. Occasionally people require surgery just to reverse some of those changes that have occurred. And in 4 out of 100 cases, there is a risk of developing onto localized cancer. So that's particularly why it's important to know this is what you've got and be managing it appropriately. Now I'm going to show some gory pictures. Yeah. So here you go. So these are the white areas, and you can see this is all very narrowed. You lose the labia. You get clitoral hooding, so the clitoris is buried underneath the skin, and there you've got sort of erosions and ulcers. So this is not just the menopause. This is something that needs active treatment, and you need to know it exists so that you know if you're getting those symptoms, you need to seek advice. So, a bit of a whiz through. So in summary, the menopause does hasten the normal aging changes that occur with the skin. The way to try and remediate that is with regular emollients, avoiding soaps, using washing creams, using good sun protection. As ever, good diet and exercise will also help reduce those age-related changes. Local HRT and systemic HRT is certainly beneficial, and pre-existing or new skin conditions can appear or can worsen at the time of the menopause. That just confuses the whole picture as well. And prevention is always better than cure. So prevention by using your sun protection and your moisturisers before you're actually in a position where your skin is problematic. So